Welcome. I'm Dr. Raed Dweik, Director of the Pulmonary Vascular Program in the Department of Pulmonary Allergy and Critical Care Medicine at the Cleveland Clinic. I'm pleased to welcome you to the Cleveland Clinic's Respiratory Virtual Grand Rounds. These are presentations where I invite some of the leading authorities in the field of respiratory medicine to discuss an important topic that I believe is worthwhile to your practice in order to help you be more confident in approaching and managing patients with a certain disease. For today's presentation, I have asked Dr. Peter Mazzone to provide you with an overview about lung cancer screening. Dr. Mazzone is the director of our lung cancer program at the Cleveland Clinic and is a frequent speaker on this topic at national and international meetings. Dr. Mazzone earned his Doctor of Medicine degree from the University of Western Ontario in London, Ontario, Canada. He completed his residency in internal medicine, chief residency, and pulmonary and critical care fellowship at the Cleveland Clinic. He is a fellow of the Royal College of Surgeons and Physicians of Canada and the American College of Chest Physicians. He is also a member of the American Thoracic Society and the International Association for the Study of Lung Cancer. Dr. Mazzone's presentation includes a historic perspective on lung cancer screening, followed by a focus on recent progress in this area that led to the current lung cancer screening guidelines. Here's Dr. Mazzone.
I want to thank you for inviting me to speak and present to you the topic of lung cancer screening. My name is Peter Mazzone. I'm a pulmonologist in the Respiratory Institute of the Cleveland Clinic. I direct the lung cancer program and the screening program for the Respiratory Institute. In the next 30 to 45 minutes, what I hope to do is provide you with a bit of an introduction to lung cancer screening, understanding the definitions and the central aspects of a screening program will help us to understand the evolution of the literature and where we are today. We'll then focus on the potential benefits and harms as they were understood from literature published prior to 2011. After 2011, there were a couple of landmark studies published that very much frame the way we think of lung cancer screening today. So that'll be highlighted in the next section. And then finally, we'll conclude with lung cancer screening in 2013. What are the guidelines and what considerations should you be thinking of if you're considering developing a lung cancer screening program? We'll start with a polling question. The first question is, which of the following are key components of a successful screening program? A is the program improves survival. The test detects little pseudodisease, is affordable and available. B, improve survival for a disease that's difficult to treat. C, decreased disease-specific mortality is the outcome. The test detects little pseudodisease, is affordable and available. And D, decreased disease-specific mortality in a disease that is very difficult to treat. As you'll see in the next couple of slides, the correct answer for this question is C, decreased disease-specific mortality in a test that detects little pseudodisease is affordable and available. So to understand the evolution of lung cancer screening, we first have to go back a step and understand what screening is. In screening, we're testing an individual who's at risk for a disease before they develop any symptoms or signs of the disease. So you're screening a healthy population who has some risk factors for the disease that you're screening for. The goal of screening is that you detect that disease at an early stage, a stage when cure or control of the disease is possible, with the main benefit, the results you're looking for in a successful screening program, being fewer disease-specific deaths in the screened population. So for this talk, that's fewer people dying of lung cancer because they're getting screened. Fewer disease-specific deaths is the main benefit, but there are other considerations for a successful screening program. First, the disease must have serious consequences in the population that you're screening, and it has to be detectable in a preclinical phase, meaning before symptoms develop. The test must be able to detect that preclinical disease at a point when you can still treat it. The test ideally will detect little pseudodisease and cause little morbidity in its performance or the interpretation of its results. And ideally, the test is very affordable and readily available to the population. So to summarize that, the balance we're looking for here is more benefit than harm. where benefit is mortality reduction, disease-specific mortality reduction, and harms are the harms of the testing, detecting pseudodisease, morbidity from testing, and the cost to society. Well, prior to 2011, we learned quite a bit about the potential benefits and potential harms of screening for lung cancer. The earliest screens used chest radiographs as the screening test. These were mass screening efforts that involved individuals from large cities. Everyone got screened. There was no control arm. And so there was no way to compare the number of deaths in those who were screened versus those who weren't. So you could not come up with the benefit of a disease-specific mortality reduction. However, these studies did show that you could find more early-stage and resectable cancers than you would have guessed, and survival rates for those cancers that were resectable were better than usual. This promise led to several controlled trials of chest radiograph screening being conducted. So one group gets the screening test and the other group does not. Most of these studies were actually different frequencies of screening, though a couple of them were screening in one arm and no screening at all in the other. And the screening tests were chest x-rays plus or minus sputum collection. What you see in this slide is that none of these studies showed a mortality reduction. They did show improved survival, however, much like the cohort trials did. There were higher survival in screen-detected cancers than in non-screen-detected cancers. They were also able to find more early-stage cancers. However, despite finding those early-stage cancers and treating them, there were an equal number of advanced stage cancers detected. In other words, there was no stage shift. A stage shift suggests you're finding early cancers and you're curing them so they don't go on to be advanced cancers. Because there was no stage shift, there was no reduction in disease-specific mortality either. I think it's important to understand the difference between an outcome of survival and an outcome of mortality reduction, because that will help us to understand how the CT screening literature has evolved over time. There are three biases inherent to the use of survival as an outcome in a screening program. The first is called a lead time bias. In a lead time bias, you're diagnosing a cancer earlier in a group you're screening than would have been diagnosed if the person was not screened and you waited for symptoms to develop. If both of these patients, the one with cancer screen detected and the one with cancer symptom detected, die at the same time, the person who was diagnosed sooner will have contributed more survival time. And so survival will look like it's improved, though there's an equal number of deaths from lung cancer, so there's no change in mortality. There is no way to avoid a lead time bias in screening. That's exactly what you're trying to do, is diagnose things earlier. The question is, did this influence the results enough that to explain why survival was improved, but not mortality? The next bias inherent to the reporting of survival as an outcome is called a length time bias. In a length time bias, the suggestion is that any test administered intermittently, such as a yearly chest x-ray or yearly CAT scan, is more likely to identify a group of indolent tumors, relatively slow-growing tumors, and miss some very aggressive tumors that would have grown fast enough to have been missed on one scan and too far advanced by the time you get the next scan. So on the whole, the population of screen-detected cancers is relatively indolent compared to symptom-detected cancers, and therefore their survival is improved. The final bias to consider is called an overdiagnosis bias, kind of an extreme form of a length time bias. In this slide, you'll see that both the screened and the control group, there are 3 cancers in each of those groups. All 3 are confirmed in the screen group, diagnosed based on screening, and one of those patients goes on to die of their cancer. The other 2 die a natural death, unrelated to the cancer, and they have both contributed to survival time. In the control group, only one of those 3 cancers ever became symptomatic and was diagnosed, and that patient dies. The other 2 are never discovered. Their patients die of another cause, and so they never contribute to the survival data. So overall, improved survival in the screen group, but the same mortality. It's hard to think of cancer as being overdiagnosed. We think of it as being aggressive at all times, but there are some indolent forms, and we have to remember we're screening a population who has risks for many other diseases, usually somewhat elderly and having smoked for quite a long time. And so they may die of another cause before cancer, even if it's not so indolent, would have taken their lives. Well, with this in mind, in the late 80s, early 90s, CT scanning became much more commonly used. And very early on, it was recognized that a small cancer that you just couldn't see on a chest X-ray could be easily detected by a CT scan. And so the thought was maybe this improved sensitivity for small early cancers will lead to better screening outcomes. This spawned a series of cohort trials. Again, in a cohort trial, everyone gets screened, so you can comment on survival, but you can't compare to a control group and therefore can't comment on the outcome we're really looking for, disease-specific mortality reduction. The first United States cohort trial of low-dose CT screening was the Early Lung Cancer Action Project, and the results here are very indicative of all other cohort trials that followed. In this study, 1,000 at-risk individuals were enrolled, and they all got a low-dose CT scan as well as a chest X-ray. And they were able to find far more cancers with the CT scan, 6 times more stage 1 early cancers with the CT scan. But they also found a lot of nodules, 3 times more lung nodules with the CT images than the chest X-ray images. The screen-detected cancers had an excellent survival. There were other cohort trials performed around the world, and all had very similar results. You're finding a lot of early-stage cancers. Survival rates for those cancers are excellent, but you're also finding an awful lot of nodules. At that time, there was a split in the screening community. Some were saying, well, look at our results. Look at the survival. It's fantastic for such a deadly disease. How can we not be offering our patients CT screening? While others were saying, well, let's remember the lessons we learned from chest X-ray screening. We agree. Here's 3 studies, 3 separate cohort trials. We're finding more cancers than we would have otherwise predicted. We're doing more surgery, suggesting there's far more early-stage cancers than we would have predicted. But there's no change in the number of advanced stage cancers compared to what we would have predicted, and no change in the number of deaths compared to what we were predicted. Again, these are all cohort trials, so these number of deaths in advanced stage cancers aren't based on a control group, but based on some risk calculators that were felt to be valid. So at this time, most people said, geez, a lot of promise, a lot of hope in terms of benefit, but we're not there yet. We really need controlled trials of CT screening to tell us if we're going to reduce mortality. Prior to 2011, we learned quite a bit about the harm side of things as well. As mentioned, one of the harms was the detection of pseudodisease, in this case, finding benign lung nodules. As the CT scanners became more detailed with the images they could provide, we were able to see very small lung nodules that we never could have seen before, even on CT scans. This finding of all kinds of small lung nodules led to further scanning, protocols to follow these nodules to make sure they're not growing, and a nice summary statement of procedures for these benign lung nodules is that for every 1,000 individuals screened with a low-dose CT, we might find 9 stage 1 non-small cell lung cancers, but we'd also have 235 false positive nodules and 4 thoracotomies for benign lesions, all from baseline screening. In addition to the potential risk of additional scanning and biopsies, finding nodules in patients leads to some anxiety. In the Nelson trial, they looked at a group of subjects and studied their quality of life, the anxiety scale. Found the day before having the CT scan, people were a little bit anxious, and the day after, that anxiety resolved to a good extent. But then for those who were told they did have an indeterminate lung nodule, the anxiety level was sky high. And for those who were said, no, you have none, the anxiety level fell quite a bit. So even though the majority of these very tiny nodules are benign, not going to bother anyone, your patient finding this out can lead to quite a bit of anxiety. We also learned a little bit about the risks of radiation from the CT scan, all from very sophisticated calculations, extrapolating from other types of radiation exposure. An example would be a 50-year-old female never smoker. If they were enrolled in a screening program through their lifetime, the reduction in lung cancer mortality from the screening program would have to be at least 75%, just to outweigh the risks of radiation and cancers that might develop. This highlighted the need to not apply this test to people who are at very, very low risk of developing lung cancer. They were also learned a little bit about cost effectiveness, perhaps a little bit early, because we didn't even know if screening could be effective, but the results made some sense. The greater the reduction in lung cancer mortality, the more likely it is that a CT screening program could be cost effective. Others commented on how this would translate into the real world rather than just a study section. And both sides of the coin were commented on. In one nationwide survey, the suggestion was that current smokers were much less likely to consider CT screening than would be never smokers. So those at risk, less likely than those who aren't at risk. And only half of all current smokers would opt for surgery if they were found to have a screen-diagnosed cancer. And that suggests that the impact of the program would be less than we might estimate. On the other side of it, another study suggested that those who choose to be screened are actually a healthier population on whole, with a higher overall lung cancer mortality, so more opportunity to benefit that group. So where were we prior to 2011? On the benefit side, we had hope that we would have a mortality reduction, but no evidence to that date. And on the harm side, we recognized we're identifying a lot of lung nodules with risk for procedures for benign lung nodules, potential for radiation risk, and unclear cost effectiveness. In 2011 and onward, there's been an awful lot of progress in this area, and most of it was driven by two landmark trials published in 2011. The first, the PLCO Trial, had an aim of determining the effect of a screening chest X-ray on lung cancer-specific mortality. They enrolled over 150,000 subjects from ages 55 to 74. There was no absolute smoking requirement to enter this screening trial. And those who were smokers had a chest X-ray every year for 4 years, never smokers for 3 years, and all were followed for a total of 13 years. About half of everyone enrolled were women, and only 10% were active smokers, whereas a full 45% of the group were never smokers. The lung cancer incidence in both the screen and control arms was about 3 times that of the general population, so at most a moderate risk group that was enrolled. There were a few more cancers detected in the chest X-ray arm. However, only a fraction of the cancers detected were actually detected by the screening test, and almost 2/3 that number during the screening period were detected between chest X-ray, yearly chest X-ray scans, far more in the observation period. There were more stage 1 cancers detected in the chest X-ray arm, but an equal number of advanced stage cancers and an equal number of lung cancer deaths occurred in both the screening and non-screening arm, with this study kind of concluding that chest radiographs, at least standard chest radiographs, are not valuable tools for screening. The second landmark trial published in 2011 is the National Lung Screening Trial. And this screening trial randomized high-risk patients to receive either a low-dose chest CT or a chest X-ray. The high-risk group was defined as people aged 55 to 74 who had smoked at least 30 pack years, and if they had quit smoking, they hadn't quit for more than 15 years. 41% of the entire group were women. Active smokers now were almost half the group, and there were no never smokers. lung cancer incidence is now about 10 times that of the general population, so this is truly a high-risk group. There were more cancers detected in the low-dose CT arm, with a much greater portion detected by the screening test, very few detected between screens, and fewer in the observation period. There were more stage 1 cancers, fewer advanced stage cancers, and finally our home run result, a 20% reduction in lung cancer mortality. Since the time the National Lung Screening Trial was published, there have been a few other controlled trials that have published mortality outcomes. A Dante trial from Italy, a Danish lung cancer screening trial from Denmark, and the MILD trial also from Italy. None of these three trials has shown a mortality reduction. However, they're all quite small and probably underpowered to show that outcome. And when combined with the National Lung Screening Trial result, the overall effect is still benefit, mortality reduction. Those other trials also enrolled slightly different risk groups and had different screening intervals and durations. So we have now our benefit side answered. Yes, we can reach mortality reduction. From 2011 onward, we also learned more about the harms. First, the benign lung nodules. In combination, the cohort and controlled trials, depending on how a nodule is defined, what size is the study going to say, yes, that's a nodule, or no, it's not. It's perhaps in the 20-25% range of everybody screened on their baseline will have a lung nodule. About 95% of all of those lung nodules are benign. Maybe around 2% of everybody who enters the screening program ends up having a surgical biopsy or procedure, be it for a cancer or for a benign lesion. Of all of the surgical biopsies or procedures, bronchoscopies, needle biopsies performed, about a quarter of them all are performed for benign lesions. So we learn more and more about the potential harms and downsides of finding these lung nodules. We also learned a little bit more about cost effectiveness, defined very differently in these studies. And this study suggests cost effectiveness will be tied very much to smoking cessation. The more you can get people to quit smoking, the more cost effective your program will be. Other examples include one looking at things from an insurer's perspective, where they said the cost per life year saved would be below $19,000. Many critics of this study, because some of the testing we used may not have been included in the analysis as much as felt it should. Another study, taking a slightly different approach, said it would cost about $240,000 to avoid one lung cancer death. Perhaps the best number, or most accurate number, hopefully soon to be published, comes from the National Lung Screening Trial, a presentation that was made to the NCI Board of Scientific Advisors, where they said from data from the National Lung Screening Trial, it looked like it cost about $73,000 per quality-adjusted life year saved, which is comparable to other screening tests. So where did that leave us? In 2013, the balance is now tipped in favor of benefit over harms for that very specific high-risk group in screening environments that are very capable of providing comprehensive care to the patients, much like was done in the National Lung Screening Trial. Many sets of guidelines have been published in the last year or two. The two that I think are perhaps most evidence-based. First was a multi-society document promoted by the American College of Chest Physicians, American Society of Clinical Oncologists, and American Thoracic Society. Here they say that for smokers or former smokers who meet the NLST criteria, they suggest annual CT screening with low-dose CT over any other screening method, but only in settings that can deliver comprehensive care, such as that provided in the NLST. Their recommendation was a weak recommendation based on moderate evidence, and their comments were that that's largely based on the lack of strong evidence about the potential harms, not about the benefit. They go on to say anyone outside of these risk criteria shouldn't be screened at this time unless it's in a study format. Weak recommendation based on weak evidence. The second is the United States Preventative Services Task Force. And they concluded with moderate certainty that annual screening for lung cancer with a low-dose CT will have moderate net benefit in asymptomatic persons at high risk for lung cancer based on age, tobacco smoking, and years since quitting. And this moderate net benefit depends on screening being performed in a very high-quality environment. This was released for public comment a few months ago, and hopefully soon will become a finalized recommendation that might lead to insurance coverage for CT screening. Many other sets of guidelines have been published by quality organizations, and in those guidelines they largely agree on the various components of a screening program that will be important to incorporate in order to verify that the program is of high quality. So with that in mind, if you now believe this evidence that benefits outweigh harms, if you believe the guidelines that are out there, you have to ask some questions when considering developing a lung cancer screening program. We'll go over some evidence behind each of these questions and then talk a little bit about the potential outcomes from our own experiences here. First, and perhaps most important, is who should we screen? The easiest answer is that you follow the National Lung Screening Trial criteria, and those are the criteria in the multi-society guidelines as well. But if you think a little bit more, a little bit deeper about it, a couple of other questions may arise. Should we select patients to screen within the NLST criteria? There's certainly a wide range of risks there. And should we offer screening outside of the NLST criteria? There's certainly some people who would have a very similar risk who just don't meet the NLST criteria. And if you did, what would you consider high risk, and how would you operationalize that? Here's an example, a study looking at the NLST group, and they divided that group into quintiles based on their 5-year risk of dying from lung cancer. And they saw in the lowest quintile, it would take over 5,000 patients to be screened to save one life. And in that group of over 5,000, over 1,600 would be found to have a lung nodule that would lead to further study of some sort. Whereas if you take the top 2 quintiles, you only need to screen 160 to 170 people in order to save one life, and you'd find only 65 additional patients with lung nodules. So a very different scenario, even within the high-risk group of the NLST. You'd have to decide, are we going to screen everyone in the NLST criteria, or are we going to be selective based on risk? The other question, what about those outside of the NLST criteria? There have been risk predictors developed to predict the risk of developing lung cancer. Perhaps the most robust developed from the PLCO data and the NLST data. Here it was compared to use of the NLST criteria. For over 37,000 smokers who were enrolled in the PLCO, they applied the NLST criteria and found that slightly over 14,000 of those smokers would have been positive and therefore enrolled in the NLST. In this group, the NLST criteria were 71% sensitive and 63% specific for identifying those who would go on to develop lung cancer. They then set the risk threshold of the PLCO calculator at a level that would identify the exact same number of positives, so just over 14,000. That level was around 1.35% risk of developing lung cancer over 6 years. Using these criteria, they had improved sensitivity over the NLST criteria without a loss of specificity. And so they made an argument that perhaps you should enroll people based on a risk calculator rather than just following the NLST criteria. Finally, the Association for Healthcare Research and Quality performed modeling based on the NLST and PLCO data, and they developed 576 different scenarios based on frequency of screening, age to begin, age to end screening, minimum PAC years, and maximum years since quitting. And looked at each of those 576 scenarios to find which were most efficient. And by efficient, they meant had the greatest likelihood of benefit with minimal harms. And they defined benefit as the percentage of cancers that would be detected at an early stage, percent and absolute number of lung cancer deaths prevented, and life years gained compared with no screening. The harms were defined as the number of CT scans and the percent of the entire group that got screened. Follow-up imaging exams and overdiagnosed lung cancers, as well as radiation-related lung cancer deaths. What they did not quantify in the model included the potential harms from false positive results, years of life with carrying the diagnosis of lung cancer, adverse effects of any treatment, false reassurance, or behavioral changes related to screening. They found their 7 most efficient models, greatest benefit compared to harm, and all of these were based on annual screening, and plotted them out. And they said, geez, it's very hard to say which of these is best, what benefit-harm trade-off is the best. What you'll notice from this slide is this green dot is the NLST criteria, and the NLST criteria didn't quite make that line of efficiency. In other words, there are a couple of scenarios that had equal or more benefit with less harm based on these definitions. The publication went on to suggest perhaps a reasonable model would be the NLST criteria with the ending date increased to 80 years old rather than 75, which falls along that efficiency line. So our next polling question, because this is such an important factor when starting a program, which of the following are the risk factors used to identify high-risk subjects for the National Lung Screening Trial? Males, active smokers, age 60 to 75 is choice A. Choice B, more than 20 pack years of smoking, asbestos exposure, and a family history of lung cancer. Choice C, the prior history of malignancy, recent pneumonia, or history of COPD. And choice D, age 55 to 74 with more than 30 pack years of smoking, and you've smoked within the past 15 years. All of these are risk factors, but which were used to identify the high-risk cohort for the NLST. As we've talked about in these last few slides, the best answer here is answer D. So once you've decided who's going to be enrolled in your screening program, your next question is how to enroll them. How will they be scheduled? This will depend a little bit on your own system, whether you're a single hospital with an electronic medical record system or a healthcare system. We have hospitals and satellite facilities that span a wide geography and are fortunate to have an electronic medical record. So we developed a lung cancer screening order, as well as what's called a lung cancer screening smart set that includes the order, consult to smoking cessation, a diagnosis to use, and then some educational material for patients. When you use the order within or the smart set or outside of the smart set, 3 educational questions come up asking about the patient's age, just to highlight they should be within the NLST range, asking about smoking history, and making sure that the patient hasn't already had a CAT scan in the last year. But you'll have to decide how to do that within your own program. We're in the very near future going to roll out a way to incorporate the risk calculator. Our patients will be asked to fill out some data, some information about themselves before coming in to see their primary care physician or specialist, and there will be a tab in their electronic medical record that could be clicked on to highlight risks of different diseases. One of those will be lung cancer. If the patient meets the NLST criteria or their risk of developing lung cancer based on the calculator is 1.5% over 6 years or greater, then the recommendation will come out as saying we recommend that this patient is eligible for screening, and please discuss the risks and benefits, and if the patient chooses, then go ahead with the screening. There'll also be some educational information and overview of the disease and lung cancer screening provided for the the clinician to try and help them understand some of these complex issues. So using the NLST criteria, and now in the near future incorporating the risk predictor, some of the things you'll have to track, and based on our experiences, despite our very best efforts, some of the screening scans are still ordered outside of the age range or the smoking criteria, and they've led to other opportunities for education. And in some people in whom the screening test was refused because they were too low risk, we saw that they went on to have a diagnostic CT scan, which is about 5 times the radiation dose. Our final polling question is, which of the following are potential harms of reduced dose CT-based lung cancer screening? Choice A is you identify a lot of lung nodules and there's radiation exposure. Choice B, you identify unrelated chest abnormalities and may cause a stage shift. Choice C, people may become anxious from smoking cessation and a loss of confidentiality. And choice D, increased smoking and a lack of effective treatment. The answer we're looking for there is choice A. You can find a lot of lung nodules and an unclear potential harm from the small radiation dose the patients receive. So in order to try and minimize some of those harms, there are other things to consider when putting together your screening program. How often do we screen and for how long? There are many studies of different design, some that aren't annual screens. One paper reviewed the distribution of early and late-stage cancers based on all these different study designs and found them to be rather similar, suggesting maybe annual screening is not necessary. However, the NLST results suggested that you had a similar number and stage distribution of cancers in each year, and the survival curves began to narrow once you observed people. So maybe you should keep screening. The AHRQ publication, the modeling publication that we just spoke of, found that annual screening had the greatest chance of higher mortality reduction, and so suggested that as their most efficient models. And others have suggested, just based on their own thoughts and review of this literature, that maybe you can scan people annually for a couple of years, then start spreading it out to every couple. Our own programs decided to follow the AHRQ modeling and screen annually up until age 80. You also have to work collaboratively with your chest radiology or radiology group. You have to ensure quality of the scans, both in performing them and in interpreting them. So we have a reduced dose scan, 1.5 millisieverts, about 1/5 the dose of a diagnostic CT. We are a health system, and we decided to start all of our scanning at our main campus, mainly for quality control, with all interpretations by our board-certified radiologists with expertise in chest imaging. For the time being, there's a charge to the patient, at least most patients, as not many insurers have picked up screening yet. Hopefully that will change in the near future. The outcomes you have to look for, you actually track the dose, make sure that you are providing a low-dose scan, and we've been very fortunate to have excellent performance of this measure. We've had some people not want to come to our downtown facility. They don't want to travel this far for their scan. Other hospital systems in the area are providing screening as well, and so there's competitive pricing. Some diagnostic CAT scans cost the patients more than these screening scans are being charged, and therefore patients are asking for screening scans rather than diagnostic scans just for the economic side of it. And we've also had to develop means to track those who are due for their next year's screening to make sure that that's recognized. What do we call a nodule? Another important question when considering the risk of this program. In the International Early Lung Cancer Action Project, they defined a nodule as anything 5 millimeters in size or bigger. They found that if they had increased that threshold to 9 millimeters, they'd cut the number of nodules found by into a quarter, and they would have only missed 7 or 8% of all their cancers. Similar results for the National Lung Screening Trial, where 4 millimeters was used as the threshold for calling a nodule. If they raised that threshold to 7, they'd cut the number of nodules by more than half and miss about 8% of their cancers. What is the best balance there? Nobody really knows at this point in time. A separate way to look at this was done by the Nelson trial. Very small nodules, they said no. Very big, they said yes. The rest they performed volumetric measurements of and rescanned people 3 months later. If it was growing slowly, they said no, this is not a nodule that we need to follow. Now that was 2 scans already. But with that model, they were 80% sensitive and over 98% specific. The other side, the flip side of that is currently guidelines suggest for a high-risk person, a very small nodule, 2-3 millimeters, should be followed in a year. If someone's guaranteed to come back for their yearly screen, then that's going to be done. But even in these very well-designed and well-run controlled trials, people don't always come back. And so in clinical practice, you may not tell someone they have a nodule, and they don't come back for their next year's screen. Overall, we've decided to call every nodule we see, at least for the time being, but we actively consider the alternatives. In collaboration with your radiologist, it's also important to say, well, how are we going to report these? Can we report these in a way that we can collect data? And in collaboration with our group, they formed a templated report that can be automatically abstracted into a registry for us. How do we evaluate a nodule? We've learned a lot from the NLST and other screening trials about the risk of cancer in these small nodules. Example here, a 7 to 10 millimeter nodule has less than 2% risk. Even an 11 to 20 millimeter nodule is not quite as high a risk as we would have guessed. There is now a screen-detected lung nodule risk calculator that's available for use that you might find useful as well. Because of the very low risk in the solid sub-centimeter nodules, we follow the ACCP and Fleischner Society guidelines where surveillance imaging is suggested with the interval between images based on the size of the nodule. For those that are larger, we've had to develop ways to track nodule management across the health system. We've developed care pathways for how nodules should ideally be managed, and we've tried to educate both patients and providers about that. For patients who end up needing a biopsy, we attempt to discuss all of those at a tumor board prior to biopsy in order to minimize the biopsies of benign lesions. Smoking cessation incorporation should be discussed. 20% mortality reduction is a home run for screening, but if you're able to get someone to quit smoking at age 50, you're reducing their risk of dying from lung cancer by more than 50%. So the success of your screening program is really going to be affected by your ability to get people to quit smoking. If you have a tobacco treatment center or something of that nature within your health system or hospital, it's paramount that they're part of your part of your screening program. How do we educate about the program? It takes a long time for people to be familiar with all these issues we're discussing today. And so education of the providers who will be ordering this, education of patients is extremely important. We've blanketed our system with various educational write-ups, bookmarks, review articles, many grand rounds, and despite that, there's still oftentimes a lack of information about the risks and benefits of screening at the provider level. We've developed a brochure that's handed out to every patient who undergoes screening so that they understand there's not just benefits, there's also a downside, and that they should make an educated decision. Finally, how do we advance the science? And we have a registry to follow about quality and quality of life issues. We are assessing novel imaging software, trying to develop biomarkers for risk prediction and lung nodule management. We collaborate with all of the other disciplines involved in lung cancer care. So overall, in this last 30-45 minutes, I hope I was able to provide you with a nice introduction about what screening is and what it's necessary to have a successful screening program, and provide you with a bit of a story about the evolution of literature related to the potential benefits, lung cancer specific mortality reduction, and harms, nodules and radiation and cost effectiveness. This led us to 2013, where most societies are recommending screening. with low-dose CT in a very high-risk group in an appropriate setting. We talked a little bit about some of the things to consider when starting your own screening program. I hope this has been helpful for everybody, and I appreciate your time and attention. Thank you.
Thank you very much, Peter. In this presentation, Dr. Mazzone discussed the potential benefits and harms of lung cancer screening and the progress based on recent landmark studies in this area and the current state of the art in lung cancer screening. After a brief discussion about what constitutes a good screening program, Dr. Mazzone emphasized the important difference between survival and reduction in mortality due to lead time bias and length time bias consecutively. Potential harms of screening include cost, radiation exposure, and false positive results that can lead to unnecessary additional scanning, procedures, and patient anxiety. Dr. Mazzone then discussed recent landmark studies and how their results are currently applied. Following these guidelines would result in a 20% mortality reduction in a specific group of high-risk individuals who are 55 to 74 years of age with 30 or more pack years of smoking. Dr. Mazzone then went over the important questions to answer when considering the establishment of a screening program for lung cancer. He also emphasized the importance of incorporating smoking cessation as part of a lung cancer screening program, which may result in a 50% reduction in mortality compared to 20% reduction achieved with lung cancer screening alone. I hope you found Dr. Mazzone's presentation on lung cancer screening to be a useful update on this topic, and that it helped answer some questions that you may have about recent developments in this important area. Finally, on behalf of myself, Dr. Mazzone, and the Cleveland Clinic, I would like to thank you for listening to this Respiratory Virtual Grand Rounds presentation.